Aortic root dilatation SP Ross procedure. Michael Rechitsky, MD. History. 13 years / a male who initially presented for evaluation of progressive dilatation of aortic root after Ross procedure. MRI. Moderately dilated aortic root, measuring up to 42 mm. Diagnosis. Aortic root dilatation SP Ross procedure. Flow quantitation also demonstrated aortic valve regurgitation. DDX Marfan's versus other connective tissue disorders. Aortic regurgitation associated with bicuspid aortic valves. Mycotic aneurysms. Discussion options for aortic valve surgery. 1. Aortic valve repair, or balloon valvuloplasty for stenosis. 2. Aortic valve replacement. Mechanical valve. Bioprosthetic valve. Homograph valve. Ross procedure. Ross procedure, also called switch procedure. Younger than 40 to 50, avoid anticoagulation. Involves replacing diseased avenue with PV. PV is replaced with allograft. Retrospective review of 301 pints demonstrated survival and quality of life was significantly better than with other procedures. Also, 13% versus 45% reoperation at 9 years. Advantages: the pulmonic valve is anatomically very similar to aortic and it will grow as the child or adolescent grows. The blood flows with less pressure through the pulmonary valve than the aortic valve, therefore a homograft valve could last longer in PV, and more tolerated even if fails. Risk of thromboembolic infection is very low, lower than for any alternative valve prosthesis. Hemodynamic performance makes the Ross operation an attractive alternative for athletes. The pulmonary autograft valve has a good chance of being a life-lasting solution for the aortic valve. Drawbacks: technically difficult and long surgery, as it requires 2 valve replacements, hence also potential to convert one diseased valve into 2. Only recommended for young patients who would tolerate a longer bypass time. The valve cusps are strong enough to withstand the systemic pressure, but the pulmonary artery wall does dilate when exposed to systemic pressure, occasionally enough to cause the autograft valve to leak. The risk of requiring reoperation for a leaking autograft valve is about 10% within 10 years after the operation. Aortic valve repair. Advantages: natural anatomy is preserved, or anticoagulation. Drawbacks: technically difficult, not an option for stenotic valves. 20 to 25% of patients will require a valve replacement within 10 years. Aortic valve replacement. 1. Mechanical valve replacement. Advantages: sturdy, designed to last a lifetime. Drawbacks: anticoagulation. 2. Bioprosthetic valve replacement. Made of tissue, but also have some artificial components. Advantages: no anticoag. Drawbacks: 50% chance of lasting 15 years or longer due to accelerated calcification and degeneration. 3. Allograft valve replacement. Advantages: best and safest option for patients with severe disease, natural anatomy is preserved or restored, and patients do not need to take any blood thinner medications after surgery. Drawbacks: limited availability, technically difficult. Expected to last about 15 to 20 years due to accelerated calcification and degeneration. Like bioprosthetic valves, homographs are not as durable in younger patients.